and welcome to everybody. This is season 3, or series 3. I sound like a video clip here. Session 3, and this is the series of Maternity in the Midwifery Hour. My name's Sue Macdonald. I'm the curator of these hours and the Maternity and Midwifery Festival, and it's my pleasure to chair this evening. Many of you will know these sessions were designed in response to the COVID-19 pandemic last year. Really our whole aim was to provide continuing professional development for midwives, for student midwives, for people who want to become midwives, or actually for anyone who's engaged in maternity care, just as an hour, because it's more manageable than going to we can't go to face-to-face events at the moment anyway. And you need information and knowledge and a little bit of kind of intellectual space at the moment because things are so difficult. So huge thanks to Matflix, who look after the video streaming from maternity experts and hold all this revalidation, all these tapes and resources. And I have to say to you, anyone who's doing an essay or an assignment or trying to do their revalidation, this is the place to go to get your updated information. Fantastic resource. Now tonight it's my delight and pleasure to be joined by Joyce Adu-Amankwa, who's a specialist hemoglobinopathies midwife, and Emma Drasar, consultant hematologist, who are on the screen with me. Welcome, Emma and Joyce. Really pleased you're able to make it, and thank you so much for making the time to be with us this evening. And many of you will recall that Joyce joined us with Rachel Keseadi before Christmas, and that session had more of a focus on sickle cell and disorder. And tonight we're going to still be looking at hematological disorders and the screening and the care that these women and families need from us. But also we're going to really look at thalassaemia, which was a little bit of a poor relation last time round. So that's going to be Emma's job to do this evening. So thank you so much for coming. Now I'm going to put each person on the spot, as we always do, with a little moment of the week. So shall we start with Emma, with a moment of the week?
So about an hour before this session, I got a text from one of my registrars, and she's just had a baby, 9 pounds 3 ounces, little
Wow.
girl. Well, not so little girl. So quite a sizable first baby, very cute. So
wonderful.
Big congratulations to Jessie and her husband.
That's fantastic, and that's a lovely piece of news at such a difficult time, isn't it?
Absolutely.
Thank you, Emma. How about Joyce? Have you got a moment to share?
A moment to share is about this COVID that is sort of gripping everybody's life. My auntie's husband was admitted to the hospital with a diagnosis, but today he's been discharged home.
Oh, wonderful. And that's such good news. That must be such
a relief.
Such joy to your heart, Joyce. Yeah. I'm so pleased. That's lovely. And I think that brings us on to the kind of section which we really highlight. I mean, we were brought here by COVID and it's still going on, and it's a really difficult time. We're in our lockdown, and the kind of statistics and the images on media are so grim and difficult to see staff coping with this really difficult time and the pandemic, and still managing with such compassion and kindness. That's the tremendous thing that we're all seeing on our TV screens and also hearing on the radio. The infections are still high. They've gone down a little bit, but the numbers of people in the hospital are still very high. And I think today was the highest rate of deaths so far, and that for every person who's died, that's a whole family and their friends left without someone very precious. And we must remember that, and remember also to think about the future, where we're going to have to support all of those members of staff going through this, whether they're in the intensive care, the high dependency, whether they're working mortuary area, whether they're working in the accident emergency department. They're going to be incredibly stressed and damaged by this whole event, and we're going to need to really think about ways we can all support each other. I always think of the NHS as a big family, and we're showing how strong we can be, but we're going to have to be stronger for a bit longer, and we're going to have to also show each other care and compassion, and ourselves as well. I think that's incredibly important. Also, so now I will say a huge thank you to those A&E departments, to the intensive cares and high dependency units who are working flat out, more than flat out. They're so busy, and we must send love and thanks to them for all that they're doing, and good wishes to them, but also their families and their friends, because they're living through it as well, and we can't forget that. And a huge also, and I always say this, but a virtual hug and thanks to those providing maternity care, maybe not overtly in the front line of COVID, but many women are suffering COVID also. As we always say, you can't cancel pregnancy and childbirth, things have to carry on. And I know that from my colleagues that care is carrying on, and the quality of the care is still very high, and still, as I said before, has that love and compassion, which is so important. So healing thoughts to those who are suffering from COVID or long COVID, and good wishes to anyone who's being affected at the moment. And a big thank you also to any of the key workers from the health service through to everybody who's keeping the country going and keeping us going and safe and well looked after. Moving on to, and that feels very heavy, I know, and many of you who are listening will feel it's very heavy, but we'll move on to a few other things, little bits of news. I suppose the biggest news is the inauguration of the President of the US, which has happened this afternoon. So congratulations to President Biden and Vice President Kamala Harris. How fantastic to have a woman, and a woman of color, as a vice president. That's fantastic, and it warmed the heart. Such a good event to see. Different, but it would be at this time. Other things that are going on, it's there was a launch of the RCM Maternal Emotional Health and Infant Wellbeing and Infant Development, and these resources and some of the references that are referred to this evening will be on the resource list online afterwards, and this one is there too. Very good webinars accessible to people. You can access them anytime if you're a member as well. And you'll all know the vaccinations are well underway. Many of you will have had a vaccination. And for those of you who haven't yet, it won't be long till that happens for you. So that's great. We're over 4 million, which is fantastic. Just again shows how fantastic the NHS is. Other news, the Embrace report has been launched. That's also on the resource page. Still disparity between the number of Black and Asian women dying in comparison to white women, but actually the rates have gone down a little bit. So it's still a report that we all need to read and we all need to take on board in our care. This week, Cervical Cancer Prevention Week. So just remind any women you know, if they've not had their smear test, go off and have it. It's also National Healthy Weight Week. I thought that was an interesting one for everybody. So reduce those chocolates and those naughty biscuits at this time. The trouble is that's a very soothing thing to have, isn't it? And for a little frivolity, it's National Penguin Awareness Day today. There you are. Yeah, you didn't know that, did you? And also, I want to wish a happy birthday to Professor Leslie Page, who will be known to many of you who had a birthday this week. And that's the kind of the news that we have. Again, a lot of this stuff is on the resources page. So do access this after, because you're not going to have time, because while Joyce and Emma are speaking, you're not going to want to miss a moment of this. So this week, okay, we're doing hematological disorders in pregnancy and care, and this is about the screening and the testing through that. And we'll start with Joyce Adu-Amankwa, specialist hemoglobinopathies midwife, and she provides antenatal care for pregnant women with hemoglobinopathy disease and offers counselling and further screening for couples who are at risk of having a baby affected by major hemoglobinopathies. And she's been doing that since 2015, probably longer if I know Joyce, because that's probably an interest deep in her. So for those of you who want to know more about either Joyce or Emma, their CVs are in full on the website, but I want to give as much time as possible to both Joyce and Emma. So Joyce, the screen is now yours. Welcome.
Thank you. Okay. Thank you, everyone, and thank you for this opportunity. The women out there needs the support. These particular women is not a new thing. Is hemoglobinopathy conditions has been for a long, long time, and is part of human life, and that needs solution. And we need to identify those at risk. Understanding hemoglobinopathy conditions. Hemoglobinopathy is the simple thing. It's a group of recessively inherited genetic conditions affecting hemoglobin component of the blood. As we discussed the last time, there's two major conditions, which is sickle cell and thalassaemia, and it is all to do with the red blood cell. And so the red blood cell is either affect the structure, which is the sickle cell, or the quantity that is produced, which is the thalassaemia. So the reason why it's important is because sickle cell babies are born, which is over 350 babies are born each year as sickle cell disease. And so it's quite important to have a screening process to identify these babies who are at risk. I did put there for the things, the condition, the effect of the sickle cell condition on every part of the body and how it affects individually. I wouldn't go into that much. Thalassaemia is a condition where the amount of hemoglobin that the blood produces is reduced. And this impacts on the oxygen carrying capacity. They usually affect either the alpha chain or beta chain. And this is example of the alpha chain, the chain inside the red blood cell itself. And this is modified, or this effect is on inheritance or the genetic mutation from each parent. And this is a bit I want to talk about that. When we're doing antenatal screening, this is where we are comparing, because each parent, the mother has 23 chromosomes, the father has 23 chromosomes. And these are the genetic makers they pass on for the development of the baby. However, if there is any abnormality in their status, it's likely to pass it on to develop the baby. And this is where it comes in with the inheritance. The condition of thalassaemia affects different people. And as I go on, I'll mention a group of people that you may not be, you may possibly be surprised to hear that affect them. Beta thalassaemia affects the beta chain. So if we go back to that chain up there, so we have beta chain on the top here, and we have the alpha chain. Now, these beta chains are passed on from each parent. And so if there is this abnormality or they being the carrier, the risk is 1 in 4 chance that they can pass on the unusual gene to the fetus or to the unborn baby. So beta thalassaemia affects the globin chain. There's 2 beta chains that need to be making beta, I read from there again. 2 globin genes are needed to make beta globin chains, 1 from each parent. If 1 or both are faulty, beta thalassaemia will occur. I move on to alpha thalassaemia. And the same, so the alpha thalassaemia gene are passed on to the babies. And as you look back from the globin chain, so 4 chains are produced, 2 from each parent. And if it's deleted, there is syndromes that can occur. And this is also affecting the oxygen capacity. This is a little example of how the alpha thalassemia deletion can be affected. So you can get back to it when you get the slide. I'm rushing a bit because Emma will talk also about the thalassemia side. However, the reason why I'm bringing this into it is that in practice, we all consider that thalassemia is a condition that is purely Asian, from Asian community, but we may be wrong to do that. However, I'm going to go back so that you can, we can see from here. The alpha thalassemia is a condition that affects Southern China, Southeast Asia, the Middle East, and Africa. Beta thalassemia tend to be more of Indian origin, Pakistani origin. Now I'm moving back to the slide I was on. This in practice, what I have observed is that sometimes we put a blanket eye to say that thalassemia occurs only in Asians, or sickle cell only in Caribbeans or Africans. However, thalassemia carriers can be found in East Europeans, like Romania, Poland, Italy as well. And in practice, I've seen several women that have come. Some are from Italy, some are from Sicily, some are from Poland, and they are all thalassemia carriers. So one thing I want to emphasize is that we don't have to put a blanket eye. So the antenatal screening is for everybody. And the reason is to identify babies that can be affected. Also, there is one condition that is also in white British, but it seems we consider that thalassemia can be, or sickle cell can be found in white British. There is an evidence, and I have seen and I have looked after a patient who is actually a Caucasian and is a sickle cell, full-blown sickle cell disease. And this is persistence, hereditary persistence of fetal hemoglobin, which tends to be in some Caucasians. So if it combined with S carrier, you then will get SF disease. Pattern of inheritance is as simple as that, as I explained before, is from the parents. So you are passing on the genetic mutation, the genetic makeup of the parent. The parents are passing on their genes to develop the baby. So we have to understand that these chromosomes, because there's 23 from the mother chromosomes, 23 chromosomes from the father, becoming 46 chromosomes. And in these chromosomes, as they pass on, each one of the 46 chromosomes has a role to play in the development of the baby. For instance, Down syndrome is a condition that affects chromosome 21. So that is why we screen all women for the Down syndrome condition. The sickle cell and thalassemia, for instance, chromosome 16 plays a role in the sickle cell, and chromosome 11 plays a role in the thalassemia. The risk of baby contracting or becoming affected with hemoglobinopathy condition is 1 in 4 chance that baby can be born without a disease at all. There is 2 in 4, which is 50% chance that baby can be born with a carrier like the mother or the father. However, this is what is very important for us. And it's 1 in 4 chance, which is 25% chance that baby can be born with hemoglobinopathy disease if both parents are carriers. What is the purpose of the antenatal screening? The public health has a role in monitoring and monitoring diseases and controlling diseases. So this is why public health have set up for antenatal screening to be done early in pregnancy. so that women can have the chances of, diagnosis can be identified, or babies who are at risk can be identified and be treated, or babies at risk can be identified and offer a choice for parents to make on their pregnancies. The purpose is to prevent infant mortality and mobility by identifying affected babies and facilitating timely transition into clinical care. Also to support women and their family to make informed decisions and early choices in pregnancy. Antenatal booking is a very crucial timing. It is very important that the midwife doing the antenatal booking, you abreast yourself with the knowledge so that you can give information to this patient to understand why we are doing the screening. And the reason is that its antenatal booking should be completed by 10 weeks. This is the requirement from the public health. And that is the journey. Oh, wow, okay. All right, and then family original questionnaire is very, very important to when you are doing booking, to get information from these patients. Prompt referral is required, but however, during this COVID time, it has been very difficult to get the standards in terms of getting the antenatal screening done by 10 weeks and referring them for counseling and referring them for P&D by 12 weeks. And so we have to leave it till when they come in for the combined screening and for the scan. And results of the condition is given by, information should be sent to the GPs and also to the community midwife, the outcome of the screening. I just want to make the awareness that the screening results for these patients, if they are referred for the P&D, if the babies are affected or not affected, even to do the screening, all is governed by the level of their understanding, their religious belief, cultural understanding. Previous affected child can also influence the decision they make. Information overload can also affect them. Labeling and stigma in the community. One point I want to emphasize is that all pregnant women with IVF treatment, with donor egg or donor sperm, also need to have need to go for counseling and further screening, biological further screening. It's so important to identify these babies who may be at risk. Public health must be notified with all this screening so that they can monitor babies who are at risk, babies who are not at risk, and see how to control the disease. Take home message. All midwives have responsibility to check for hemoglobinopathy status of the pregnant woman. Family original questionnaire is very important in the processing of the and getting the results for the screening. Since 2019, public health have requested that in every pregnancy, both the biological father and the biological mother need screening. And IVF pregnancies by donor egg must be referred for counseling. Timing of the screening is important. However, during this COVID is the problem. We are not able to achieve as we should. Thank you.
Thank you, Joyce. Thank you, Joyce. Now, I'll just say to the audience, and I know there's loads of you out there listening in, though it feels to us like we're just having a chat. If you have any questions, do send them in through the live Facebook, and it'll come through. And this is why my eyes are going over there every now and then, because it comes through on a different screen for me to throw at Joyce and Emma. And I know you'll have some questions for Joyce and Emma. So please do send them in plenty of time. That's great. Thank you very much, Joyce, for setting the scene on that and the important areas about screening and the impact of COVID so far. It's really helpful to start us off with. So we're moving on now to Dr. Emma Drasar. I hope I've pronounced that right, Emma. After that, Emma trained at St Bart's and the Royal London University of London, and qualified in 2001. She was appointed as a haematology consultant at Whittington and University College Hospitals, London, in 2016. And she's done obviously her haematology training at King's College, and was appointed a clinical lecturer there also. And completed her PhD based on research, I'll have to do this slowly, into markers of severity and predictors of organ dysfunction in sickle cell disease. So a very knowledgeable person indeed. She's also the North Central London and East Anglia HCC lead for sickle cell, and the North Central West London and East Anglia HCC lead for thalassaemia and rare anemias. And that's obviously her specialist interests, alongside sickle cell and hemochromatosis. So Emma, welcome. The screen is yours now. All yours.
Great. So I'm going to talk about pregnancy in beta thalassaemia mainly. So as Joyce was saying, what we're trying to do with the antenatal screening programme is to try and have awareness of babies that may be at risk of being born with significant hemoglobinopathies. And that's because for the child, the baby, the child, the parents, as that child grows up and becomes an adult, it's a significant health burden on that person. And it's also very important, as Joyce was saying, that they are able to access care and support appropriately, literally, almost from birth. So as Joyce was saying, in beta thalassaemia major, there's a disconnect between the amount of globin chains produced. So a change in the gene means that there's inadequate amounts of beta globin genes produced, which leads to an excess of alpha globin chains. And those excessive alpha globin chains cause damage and destruction to the developmental red blood cells in the bone marrow. And patients with thalassaemia major or transfusion-dependent thalassaemia are dependent on blood transfusions to sustain life. Then there's what used to be called thalassaemia intermedia, non-transfusion dependent thalassaemia, which is classically thought of as a less severe condition. However, they can go on and develop significant problems, particularly as they get older. And there's sufficient hemoglobin produced. They may be producing some beta globin chains, a normal amount of alpha chains, and so the ineffective erythropoiesis isn't as marked, and they can usually get by without transfusions, although may need a period of transfusions for concurrent illness, pregnancy, or potentially around puberty. So I always take, with my thalassaemia ladies, I always take things in stages. So as Joyce has clearly illustrated, one of the important stages is preconceptual counselling and the risk of having an affected child. And that obviously depends on their partner or being screened also. There's about 20 to 30 children with thalassaemia born each year. Historically, this was mainly, my older patients tend to be from Cypriot or Italian backgrounds, Turkish Cypriot patients. But as Joyce was saying, most of my younger patients are from the Indian subcontinent. But, we still get new patients every year from around the world. You also want to think about the risks to the mother during pregnancy. So you want to go through with her what the potential risks to her are, and particularly you want to think about the transfusion history as well with the patient. Do they have any alloantibodies that could cross the placenta and cause hemolytic disease to the newborn? Have they got significant iron overload? And what treatment are they taking to reduce that? So what are the risks to my ladies when they become pregnant? So one of the main ones is that when you're pregnant, you get an increase in blood volume, and that relates to about a 40% increase in cardiac output during that pregnancy. Now, if the heart's not functioning particularly well due to iron, or the lady perhaps hasn't been regularly attending her transfusions or was previously non-transfusion dependent, she's going to be more anemic. That heart's going to have to work even harder. Other things, some of my ladies have low bone density, perhaps due to having low bone hormone levels during their life. And babies being pregnant can exacerbate osteoporosis. So you want to try and optimize ladies from that perspective as well. We normally stop chelation treatment. So chelation treatment is what we give women and men who are on transfusion programs to remove the excess iron from the body so it doesn't build up. During pregnancy, we try and stop that. And we also try and stop that for ladies who are undergoing fertility treatment as well. So what's the risk to the fetus? We want to think about the risk of them developing a major hemoglobin disorder. Quite a few of my patients have diabetes as a result of previous iron overload or other risk factors, and there's a fourfold increased risk of issues in diabetic mums. And also we want to think about ovulation induction. That's very carefully regulated in the UK as to how to reduce the risk of multiple pregnancy, but other centres in other countries it's less regulated. So what do we want to do? This is ideal world scenario. We want to prepare, okay? I want nice planned pregnancies. I don't get my wish quite a bit, but it's a nice thing to want. And that's so we can prepare the girls so that they're in good shape going into pregnancy. So we really want to get that iron out of them so that they're fit and will tolerate the physical rigours of being pregnant. So ideally we want their TT star, which is the measurement we use to measure iron in the heart, at a normal level. So that's above 20. We want their liver iron as low as we can get it, around 5 would be ideal. And we want to stop the chelation. We want to switch them from their usual chelation, which might not be suitable with pregnancy, such as Exjade or deferriprone, onto Desfral in the time coming up to them becoming pregnant. You ideally have a 3-month washout of oral chelators before a lady starts trying to conceive. And it's the same with the chaps from a sperm perspective as well. So you then stop they're on their Desfral, they get a positive pregnancy test. You then stop their Desfral. Pre-conception, you want to make sure that they're do an all glucose tolerance test, make sure that they're not diabetic or pre-diabetic, and do thyroid function as well, because that can also be affected in thalassaemia as the result of iron loading. You want to make sure they're well supplemented with vitamin D and that they're on regular folic acid. And if they have been splenectomized, you want to make sure they're up to date with all their immunizations. And you want to review all their other medications to make sure they're not on anything else that would be contraindicated in pregnancy. So some of my ladies need a bit of help getting pregnant, and we refer to our link obstetricians and fertility specialists for ovulation induction. And we use clomiphene, gonadotrophins if they're hypergonadal, and then scan and use HCG to trigger ovulation. some of my ladies undergo IVF, and it was a very important point that Joyce made about if they use donor egg or donor sperm, that those donors are screened for hemoglobinopathies, because that's very important, because most of my ladies, well, all my ladies will have 2 affected genes, and so it's important that that the other person is, if the donor sperm is not a carrier of hemoglobinopathy. So what we do in some of our ladies is we'll particularly those who perhaps have had borderline iron control, or have had a significant increase in their transfusion requirement, or have had a history of significant iron overload, we'll reassess them at 28 weeks and get a cardiology review. Sometimes we'll actually restart desfrau in the 2nd or 3rd trimester if it looks like they're loading a lot of iron into their heart. If their TT star has fallen to 10 milliseconds, then we would definitely think about starting them on back on desfrau. Otherwise, it's more of a risk assessment that we do. And the reason why that is when you've got a lot of iron in the heart, there's a risk of arrhythmias, such as severe ones like VT or, God forbid, VF, and also a risk of heart failure as well. So we have a joint specialist clinic for high-risk pregnancy. We also risk assess our ladies from an anticoagulation perspective, think about aspirin and low molecular heparin, and we try and keep their hemoglobin above 100. We also do monthly fructosamines to monitor them from a diabetic perspective. And again, remember alloantibodies, you may, just because they've, an alloantibody in a thalassaemia patient is just the same as one in any other pregnant lady. So always think about, do we need to be doing levels, and think about the risks of hemolytic disease in the newborn as well. So with delivery at UCH and the Whittington, we give IV desfrau, 2 grams IV over 24 hours for the duration of the labour, because there's a risk of acidosis, and that plasma-free iron can be released into the system, and non-transferring bound iron can be released into the system, and then that can cause potentially cardiac toxicity as well. So we hook our ladies up to a little infuser. Historically, my older thalassaemia ladies had quite short thoraces and were quite small stature, and so we sometimes they would have a high risk of elective, say, a C-section, and you want to actively manage the 3rd stage to minimise blood loss, and also consider postpartum thromboprophylaxis for 6 weeks. So there are increased risks of pregnancy in our ladies. They come up a lot in exams, certainly in medicine. I'm not sure about for midwives, but they're often around a lot in specialist clinics. And clear and careful discussion, ideally pre-conception, is required. Thank you.
Fabulous. Well, what a fantastic well, not just an overview, but a very detailed information. It's very useful for me to have a little refresher on that. And I'm sure the audience are going to be really interested in some of the content. I have had one question. And it's coming through on the wrong screen, of course, who is said, well, I've got a question. I think this might be for Emma from Mavis. Hi, Mavis. Is there a coordination of hemoglobinopathy testing for egg or sperm donors?
It seems to be done. It's mainly done sort of in-house by the clinics. So certainly for the fertility centres that we use that operate out of UCH, then we do the in-house testing for the donors. But at a national level, I'm not sure that there is, and I don't think there is for the private clinics. either, as far as I'm aware.
I don't know, do you have a view on that, Joyce?
Yes, I cannot say, even if they have screen in the private clinics, because you want to get proper, or you want to get the evidence of the screening.
Yeah.
And so what the public health also, if I'm sorry, I got the question right, but what the public health require that for the treatment, wherever they have found it, if the biological father is not present to be tested, or if both are donors, it's important to contact the centers to get the screening report to send. But that is not an easy task. Sometimes we have to remember that some women are having IVF treatment outside UK. And several times I have followed up and nothing comes out. The women are very good. Some of them will give you details of the clinic and the person to contact, and it comes back with nothing, no report. And so in this case, then we have to rely on the neonatal screening between the 5 to 7 days old when the babies are born.
Okay.
Which we just have to make them aware of the risk of hemoglobinopathy disease if the donors are both carriers.
Yeah. And
so that is what I know. But if we cannot get the report from the centers, that is the next approach to have.
Okay. So there's a fail-safe sort of mechanism.
It's a fail-safe, yes.
Yeah. Okay. That's a good point. I think the point about that some women may seek donors from other places or have their treatment elsewhere that's a very good point. That's grand. Okay, I've got a question from Chris Warren, who says, Joyce, are you saying that termination will be offered if the baby has a 1 in 4 chance of having thalassemia, or did I misunderstand that?
Okay. What the screening is about is to identify if the baby is affected or not. So during the counseling, you are presenting the evidence to the woman or the couple, and they have to make a decision to either go ahead to have the prenatal diagnostic testing, which confirms that the baby is affected or not. And so if the baby is affected, they are given chance. And if they want to terminate the pregnancy, they are given chance to terminate the pregnancy. They have to make the choices about their pregnancies. That is why it's important to have the screening, the antenatal booking blood done by 10 weeks gestation, so that the screening the counseling can be done between the 11, 12 weeks. So then they have offered that if they're going to be offered, they want to be terminated by 14 weeks, they've already been offered the termination. And it does help with their decision making because they find it to be early pregnancies better than going over 15 weeks, over 16 weeks. And their decision to terminate becomes more complex.
I mean, it's a terrible decision to have to come to for any pregnant woman and her family, and a difficult one. I think we're going to be exploring that a little bit later in the series, which will be very interesting. So thank you for that, Joyce. I mean, I've got a question from Julie Mulhern. Hi, Julie, who says, can you tell me a bit more about what the counselling should have involved? And I guess what's interesting is, Joyce and Emma, you're both doing counselling. So maybe both of you could come up, maybe we start with Emma and then Joyce to talk a bit about what the counselling includes.
Yeah, so I tend to counsel ladies and their partners, and the male, I've got male patients as well, I counsel them as well, who have the condition and are living with their hemoglobinopathy, be that thalassaemia or one of the sickle cell disorders. Quite often the patients, because they've got experience of that disorder, have quite strong views about not having an affected child. Not always, I have to say. So they will come to me, and certainly when I do transition work with the younger adults, that is something that I will raise at our first meeting. You know, do they have a partner? Are they aware? Go over the inheritance of hemoglobinopathies again. I also, like Joyce mentioned that, you know, inheritance, the hemoglobin genes, be that beta or alpha, are not linked to your racial, you know, where you're from, the colour of your skin, your eye colour, anything like that, you know. And I do have 3 or 4 sickle cell patients who appear Caucasian, you know, they look British. So it's, you know, so it's about that sort of thing, because often I've had people say, well, my girlfriend's from, you know, Italy, it doesn't matter. Yes, it does matter. Get screened. And it's about giving them that informed choice. You know, it affects, you know, sometimes it does affect people's partner choices. I've had patients split up with their partners because they found that they had sickle trait. You know, so it can, you know, it can be a significant thing for some, very significant thing for some people. But I think as well, you know, for my female patients, it's about counselling them potentially for the interventions that they might need during their pregnancy, because they're far more likely to end up having a more medicalised pregnancy than someone without a hemoglobinopathy. Lots of my girls sail through, no worries, but there are potential risks for them that they need to be aware of.
Oh, that's great. Thank you, Emma. How about Joyce? Your take on counselling?
I want to just mention and correct myself here when I was saying that we put a blanket eye. It's not a blanket eye, it's a blind eye.
Yeah.
And then we shouldn't put a blind eye to say that I'm not a carrier. There is a lot of denial out there. And so that is why I think public health has done very, very, very wisely that they put, as I correct myself again, it's a blanket screening. So what it does, I use that term, it's a blanket screening. It doesn't matter where and who and how and where you're coming from. Everyone, as much as the person is pregnant, needs that screening. And so having to have a patient or a woman, a couple, it tends to be that sometimes the man is not available for testing. However, we don't have to leave it like that because he's not available for testing. We need to follow up in terms of discussing either the woman wants to go ahead to have a PND to test, or have a wait for the neonatal screening between the 5 to 7 days. And so the challenge out there is the denial a lot, and then the stigma as well. That's I was saying. And there's cultural, influences, and the decision that women are making, or all of us will make about our lives, and also for them with their pregnancies, is sometimes based on the religious belief they have. So it's also important. So hemoglobinopathies, it's not just when they are disease that it becomes a problem or a condition that needs more attention to look after, but also being a carrier may not affect them now. However, in their pregnancies, it does spring up, and the decision they have to make is where the challenge is coming. So whichever way you tackle hemoglobinopathies, either it's just a carrier or being affected by the disease, is an issue that needs to be, compassionate addressing it, giving them time to make decisions, giving them the evidence that it's not just evidence, but helping them to understand that it's about the red blood cell, it's about the oxygenation level in the blood, it is about them making decisions about the pregnancy. So present it to them. So it's important to also use diagrams, interpreters to help people who can't understand, which is very common there. Use other, anything that will support the woman sitting in front of you or the couple sitting in front of you to understand the risk that is it to the baby. understand the condition, the risk, to the baby, that will help them to make a decision. If they choose not to terminate pregnancy, because that is not you're not going to force them to terminate the pregnancy. That is not, whatever decision they make, they have to be reassured that they would be supported. And it does not end there when they have not consented for the PND or they have not terminated the pregnancy. The care has to be continued, because the midwife, we have to pass it on to the health visitors or the specialist nurses if the baby is affected. So the care is ongoing in order to control morbidity and mortality. Thank you.
It's a huge issue, and I think it's interesting, the sort of aspects of stigma and about the sort of fault that people will perceive, like one couple, one might perceive, oh, it's your fault, or it's both our faults, and the potential for, and I think Emma mentioned about breakup. I mean, that's a huge potential for awful breakup and tension and pain within a relationship. So that was really great from just a little counselling there. Thank you so much. And I've got Martha says, Joyce, can thalassaemia be cured?
Yeah. Yes. So
we have to work hard at it. It can't be cured. There are recently gene therapy, but it's not that easy. It's not that common. Some countries are doing it, and I think it can be done. It can be done. I think Emma can help with that in that sense.
Yeah.
So
good question.
So for the affected children, if they have a matched sibling, they are offered bone marrow transplants at a young age. When I say young age, I'm talking, under 7, as early as we can do it, they'll be transplanted. But that has impact on the child, the family, impacts on that child's future fertility, things like that. But that is a curative treatment. There's, as Joyce mentioned, gene therapy. So that's new. There's several trials ongoing in London at the moment. There's and the results are very good, but it's still a transplant. It's still 4 doses of busulfan chemotherapy, 4 days, and it's what we call a myeloablative transplant. So it's not a sort of an easy ride for that person, and there is a potential risk of dying during that procedure.
Wow.
Brilliantly, though, there are other treatments now that are coming through to try and make the ineffective erythropoiesis less severe, so that will reduce potentially people's transfusion requirement and therefore the amount of chelation that they can take. So these are cures. They will render patients not transfusion dependent, but potentially any of the historic damage that may have occurred due to iron or other things, we just have to manage those and treat those. But there's been more progress made in the last, what do you think, Joyce, in the last five years with research?
Yeah.
Like all these new treatments. But I think the thing that has made absolutely. But one of the things that has made the most difference to the outcomes of children, certainly with sickle cell, is the introduction of penicillin for the babies. Right. Because that's one of the massive purposes of the screening program, is so that the babies get started on their penicillin, because that's what killed and still unfortunately does kill a lot of affected children with sickle cell disease in some parts of the world, was invasive pneumococcal disease.
All right, that's really helpful as well. Thank you so much. I think we've only got there's lots of questions coming through. We've got let's see, how about Christine Just, Where transfusion is required, how often would this be necessary? Are there any risks associated with ladies that only have the thalassemia tray or sickle cell tray? That's 3 questions, Christine.
Yeah. So if they're an affected person, be that sickle cell or so say thalassemia, if they're if they were normally transfusion dependent, then usually they're transfused every sort of 3 weeks. And we just find that instead perhaps of them having 2 units every 3 weeks, they might need 3 units every 3 weeks. So we get around it that way. For our non-transfusion dependent ladies who perhaps need transfusion during pregnancy because of the dilutional effect of the volume increase, perhaps going from a hemoglobin of 80 down to a hemoglobin of 70 or 60, and becoming more symptomatic, we basically judge it on the person, so we transfuse them as required, really, rather than putting them on a really strict transfusion regime. Now, for the trait patients, this is a big thing, okay? So patients who have thalassemia trait have small cells and can become anemic during their pregnancy. So they may normally run a hemoglobin of 110 or 100, but during pregnancy, I have ladies in my clinic who drop their hemoglobins down to about 80 sometimes. And then it's important to think, do they actually have iron deficiency? It's very important not to overdiagnose iron deficiency in beta thalassemia trait patients because the blood findings can be quite similar. And often what you find is that people with thalassemia trait can have been given loads of iron during their lives and can actually become iron overloaded. So it's important to definitely always think, is this lady iron deficient? And discuss, that's the sort of patient that I get asked about a lot by my midwife colleagues and my obstetric colleagues. So never be afraid to flag that sort of lady up. Sometimes we do end up transfusing those ladies if they are symptomatic from an anemia or if there's poor growth on their scans. So, but that's the sort of patient who's definitely, just like with my other ladies, MDT approach.
Fab. That's fantastic. Now I could listen to you all, and I know there's a lot in the audience who are desperate for our questions to be answered. So I'm hoping that Emma and Joyce might be able to answer a few questions online, because we have to be rationed. We have an hour every week, and I'm so sorry to those who put some fantastic questions, and thank you very much for posing the questions. And thank you so much to Joyce and Emma who've spent their time sharing their expertise with us. It's been absolutely fantastic. And really, someone has already said how fantastic it is to have a refresher course, because she's just recently been looking after someone with thalassemia. So it was really helpful. So fabulous, you see. You're so current. So thank you. Thank you to Emma and Joyce for joining us. And I'm very happy that I've managed to twist both Joyce and Emma and Rachel's arms, and they're going to come back in a few weeks to look at some of the challenges that aren't quite as in the textbook type challenges. And I think the audience will find that fascinating. Just from the short chat that we had yesterday, I found it fascinating. So you'll enjoy that. So please, I'd like to say thank you to Matflix for the video content. Thank you to the Practicing Midwife Journal and All for Maternity for their support. And just to remind the audience, there are resources available on the webpage, so do use those as you wish. Now, next week, we've got Mark Williams, who's going to be talking about dad's mental health and well-being, and someone else that you know, there's usually 2 people at least on the maternity hour. So I want to say a big thank you to our speakers, but also thank you also to Catherine, who's in the background making sure everything technical is working. And thank you to you, the audience. You've been fantastic. Please stay safe, look after yourselves, and give your loved ones an extra hug. Take care.
Thank you.
Thank you.
The Maternity and Midwifery Forum brings you Matflix, video streaming from maternity experts. All your CPD and revalidation needs met in one place. Our expertly curated box sets are the perfect way to engage with the latest thinking, issue by issue. They make revalidation easy and are the perfect accompaniment to any project or university coursework. In addition to video from expert speakers across maternity and midwifery, there is easily accessible research and links to the latest government policy documents. Our reflective questions at the end are the perfect primer for your revalidation. In the same way the Maternity and Midwifery Forum provides certificates to show that you have attended these festivals, we can provide certificates for those who have consumed the content of a box set and submitted their written answers to the reflective questions provided by our curator, Dr. Jenny Hall. Midwives, maternity professionals and students, do not miss out. Subscribe to Matflix today. Box sets are just £17.50 each, or access to them all starts at £8.99 per month, and only £5.99 for Maternity and Midwifery Festival attendees. Students pay just £2.99 per month, and only £2.49 for Student Maternity and Midwifery Festival attendees. Check out the box sets at www.matflix.co.uk.